educational content by Dr. Mohammed Al-Nagi Mohammed. In this explainer, we're going to give you a practical, high-yield framework for tackling a pretty common clinical challenge. So let's talk about hyperprolactinemia. We're going to build a really practical framework for how to approach it. This is honestly one of the most common endocrine issues you're going to see, so having a structured approach is absolutely essential for getting the diagnosis and management right. Okay, so picture this. A lab result comes back. Raised prolactin. It's a common finding, sure, but the list of possible causes is huge. A systematic approach is everything here, so you don't miss some critical pathology. We'll start right at the beginning, with the physiological fundamentals. Before we can even begin to understand what goes wrong, we have to get a solid handle on what's supposed to happen normally. So let's do a quick review of the physiology of prolactin secretion. So what exactly is prolactin? Well, it's a hormone pumped out by these specialized cells called lactotrophs in the anterior pituitary. Its main job, the one everyone knows, is stimulating lactation. But its effects are systemic, which explains the really wide range of symptoms you can see when there's too much of it. Now, here's what's really interesting and a bit unique about this whole system. Most pituitary hormones get a go signal from the hypothalamus. Prolactin is the opposite. It's primarily under inhibitory control. Think of it like this. The hypothalamus is constantly releasing dopamine, which acts like a brake on the pituitary, telling it not to release prolactin. So what happens if that dopamine brake is removed or blocked? You guessed it. Prolactin levels are going to go up, and that single piece of physiology directly informs how we treat this. It's so logical, right? If a lack of dopamine's braking action is the problem, the solution is to reapply that brake with medicine. And that's exactly what we do. We use dopamine agonists, like bromocriptine or cabergoline, to directly suppress prolactin secretion. This is a crucial concept for both your exams and your clinical practice. Okay, so we've got the control mechanism down. Now, how does too much prolactin actually present in a patient? The symptoms are a direct result of its hormonal effects, and they differ pretty significantly depending on the patient's sex. In women, the classic presentation really centers on reproductive function. High prolactin just disrupts the normal ovulatory cycle, which leads to amenorrhea, that's the absence of periods, and often galactorrhea, which is that inappropriate milk discharge. In men, the presentation can be a lot more subtle at first. You're looking for things like impotence and a loss of libido. Galactorrhea can happen in men too, but it's definitely less common. So here's a crucial point on examination, especially in men. You have to be able to tell these two things apart. Galactorrhea is the secretion of a milky fluid from the nipple, and it's driven by prolactin. Gynecomastia, on the other hand, is the actual proliferation of glandular breast tissue. That has a completely different set of causes, usually related to an imbalance of estrogen and androgens. Okay, so we've identified hyperprolactinemia. Now the detective work begins, finding out why. We can pretty much break down the differential diagnosis into three broad categories: physiological, pathological, and drug-induced. First things first, you always have to consider the physiological causes. Pregnancy is the most important one, hands down. But other factors like significant physical or emotional stress, really intense exercise, and even sleep can cause a temporary bump in levels. These are usually mild and should be ruled out from the get-go. All right, moving on to the pathological causes. The most common cause is a prolactinoma. That's a benign pituitary tumor that's overproducing prolactin. Other really significant causes include primary hypothyroidism, acromegaly, and of course, polycystic ovarian syndrome, or PCOS. Let's focus on primary hypothyroidism for a moment, because this is a classic exam topic. Here's what's going on. When the thyroid gland fails, the hypothalamus releases way too much thyrotropin-releasing hormone, or TRH, to try and stimulate it. But that TRH has a secondary effect. It also directly stimulates the pituitary to release prolactin. This is why checking thyroid function, specifically TSH and free T4, is an absolutely essential step in the workup. Now let's turn to one of the most frequent culprits you are going to see in your everyday practice: medications. Let me be clear. A thorough drug history is completely non-negotiable when you see a raised prolactin. And this all links directly back to our core physiology. Any drug that blocks dopamine receptors can effectively release the brake on prolactin secretion. The classic examples are dopamine antagonists like metoclopramide and domperidone, and many antipsychotics. You should also keep some of the rarer causes in mind, like SSRIs and opioids. Okay, we have covered a lot of ground. So let's boil it all down to the absolute must-know points for your exams and for your next clinic. Let's really consolidate these key takeaways. First, remember the central principle. Dopamine inhibits prolactin. Second, your initial workup has to include a pregnancy test in women and a thorough drug history, always. Third, check thyroid function to rule out that key reversible cause of primary hypothyroidism. Fourth, a prolactinoma is still the most common pathological cause. And finally, never forget that the clinical presentation is going to be really different in men versus women. So to really solidify this framework, think about this. After you've ruled out the physiological and drug-induced causes, how does the degree of prolactin elevation, the actual number, guide your next steps? When do you move toward imaging versus doing more endocrine testing? Making that distinction between a moderate and a really significant elevation is absolutely key to an efficient workup. Thank you for joining this explainer on hyperprolactinemia.